Almost every year we hear new formulas coming up. To talk on new formulas, we have an encyclopedia and biometry. Ramesh sir, welcome sir.
Thank you. So regarding the true K measures the front and the back, and then it calculates the actual true K of the cornea. It is found to be most useful when used in patients where you have a dissonance between the front and the back, like in ectatic eyes and thin corneas, and in keratoconus and post-classic eyes. For the normal, regular eye, still the standard anterior K is fine. So my talk today, thanks Atik, you asked me to talk about Barrett's and Kane formula, and excellent. We all heard about David Chang, former president ACRS's comment that true happiness will be there for the patient when he gets 6 in any one eye. Can you just put your hands up? How many of us are using SRK2 formula? Yes. Thank you. So for over 25, 30 years, I've also used SRK2 formula, and most of us have. SRK2 formula, SRKT are great for the majority of the eyes which have a normal anterior segment and a normal axial length range. But we do have eyes like in the extreme zones. We have buphthalamus, nanophthalmos, microcornea, axial hyperopia, extreme eyes where a two variable formula like SRK2 or T is not enough. Norsby's seminal study showed that errors in calculations come from three sources. A third of the error is because of calculation error. A third is because of measurement error. We measure an inaccurate K or an inaccurate axial length. And one third is actually a result of refraction. Refraction lane length is not correct. The refractionist is pushing too much minus or plus. Now we are today concentrating on the IOL formula error and how to reduce this particular component. Before 2010, most of us, the elder, senior, older ophthalmologists were using half a Q for small eyes, SRKT for longer eyes. This was what we were all doing. After 2010, we started using Barrett's Universal 2 group of formulas, and we were very, very happy, and we all felt that we were on top of the game. After 2010, in the last several years, Barrett's 2, along with EVO or emmetropia verifying optical formula, the Kane, Nasser, Olsen 2, Panacea, Pearl DGS, the RBF of Warren Hill, T2, and VRF, and other formulas have come in, trying to plug the gap and make it more possible to get better results with extreme eyes. Publications show that only 50 to 70% of our patients are within half a diopter of emmetropia with the older formula. And with the newer formula, 70 to 80% of our patients are within half a diopter of emmetropia. We saw that for a normal average eye where you're putting an intraocular lens of between, let us say, 20 and 22, any formula will do well. But if you have a short eye, if you have a microcornea, if you have unusual eyes, the old two variable formulas are not enough. Let us see what has happened in 2017. 2010 to 2017, all of us who are using Barrett's Universal 2 became very happy when this particular review article of 18,000 and all patients by Ronald Mellis et al. Came out. Jack Holliday was a co-author of this paper, and the conclusion was overall Barrett's Universal 2 gave the lowest prediction error. So we're all very happy. We're using Barrett's, we're using the best. This is one of the pictures from within the presentation. This is the mean variable, and this is the 0.25 error. If on the left and right, you can see various lines, the blue line, the yellow line. Those are all the different formulas which were used to this group of 18,000 patients, which are all post-op. We knew the pre-op values, we know the post-op outcome. And we can see that in all of them, that the central zone, any formula works. In the extreme zone, most formulas don't work. There is a big variability in outcome when you have a IOL power of plus 10 or a plus 30. So extreme IOL powers, none of these formulas work well. In 2019, the same group, Ronald Bellis, this time with Kane and Thomas Olsen, again redid the calculations, and this time he came to the conclusion that overall KANE formula was the most accurate with 83.1% of eyes within 0.05 diopter of predicted outcome. So KANE is slightly better than BARRETS overall. Here we can see two blue circles. The circle on the right circles Holiday, SRKT, and Hofeq, the older generation of formula. The circle on the left covers KANE, Olsen, and Barrett's U2. So you can see there is a 10 to 15% increase in accuracy with the same measurement if you just shift your formula to Barrett's Universal 2 or KANE. Olsen is still now a paid formula, so most of us are not using it. In 2020, there is a nice review article by Savini et al. Please go through that. It describes all the modern formulas, how they work, and how well they are doing. What has happened in the last 2 years during the COVID time? Here is a nice review article comparing the accuracy of several formulas for eyes with extreme axial myopia, that is more than 29 millimeters and more than 31 millimeters. So on the left, you have extreme myopia more than 29. On the center, you have extreme myopia axial length more than 31. And if you see, some of the best are Evo, KANE, Olsen, and Barrett's. So these two are still far better than SRKT and Haigis. I hope this presentation pushes you to stop using SRKT and Haigis for these very long axial myopia eyes and start using KANE, Evo, Olsen, and Barrett's Universal 2. One more concept has come up recently where you call it segmentation of formula. If your axial length is 29, please use KANE. If your axial length is 31, please use something else. If your axial length is less than this, so different segments of the axial length need different formulas for the best outcome. So this 2022 review in January showed that KANE formula had a mean prediction error close to 0 for high myopia. Session ends in 10 minutes. Thank you, Ma. We'll finish in time. So KANE is better, especially when you have very long eyes. This is an example of one of my patients which I implanted 4 days ago. KANE says put a plus 15, while Barrett's Universal 2 gives a plus 0.50. So KANE pushes you to the next higher power. Mean prediction error is closer to 0 in high myopia. This is one take home. Let us come to the hyperopic end of the spectrum where the IOL powers are like 25, 26, 30 and above. Here is a very interesting 2022 comparison. This review article reviewed several studies, 14 studies with 1,475 eyes. Very difficult to get 1,475 short eyes. And the conclusion was the Pearl DGS had the highest percentage of eyes within 0.25 error. What is a Pearl DGS? It's an artificial intelligence-based open source formula. It's the formula code is available online, unlike most of the other modern formulas. And we're all familiar with Gataniel. He has done a lot of work on the cornea from Paris. So he and his co-workers have got the Pearl DGS formula. So in conclusion, in extremes of axial length and corneal measurement, please think of using KANE for high myopia. Consider Pearl DGS for very short eyes. Think of EVO and Hill RBF. Hill RBF gives you the boundary zones and tells you whether your formula is correct or just guessing. And we can all expect incremental progressive improvement in the current generation of formula, which use regression analysis and artificial intelligence to improve themselves. Thank you.
Thank you so much, sir. So my take home is today I've learned that there's a new formula called Pearl DGS. One formula fits all is not the key. Customization can be done and has to be done. Thank you.